Dr. Maneesh Singh for the first talk, who will be talking on right way to start and escalate therapy for 7 minutes. Please, audiovisual can set the timer to 7 minutes. Dr. Maneesh is currently the treasurer of GSI and the local boy here. Dr. Maneesh, all yours.
Thank you, sir, for the opportunity. And so I'll be speaking on the right way to start and escalate therapy. Just 7 minutes, so I'll just highlight 7 key points. One very important point, especially for the young practitioners, is you diagnose before treating. So very important thing, what happens, in a busy glaucoma practice, what happens, you are mainly treating the intraocular pressure. So pressure is 24, you add medicine, you have reached your target, you are happy. So sometimes it happens you're treating the intraocular pressure more than the glaucoma. So especially, it's very important you write the diagnosis. When you write the diagnosis of, say, a secondary glaucoma, it makes you think, what is the cause of glaucoma? Have I taken the history of steroid? Have I looked into angle recession? Whether I've seen the pseudo exfoliation? When you write diagnosis of primary open-angle glaucoma, it makes you think whether done a gonoscopy or not. So always write your diagnosis before you start treating your patient. Also very important, before setting the target pressure, try to do a risk profiling for your patient. Look into the life expectancy, what is the level of damage, mild, moderate, severe, what are other associated risk factors, whether there are any disc hemorrhages or not, what is the status of the other eye. Based on that, you can get an idea whether it's a high risk patient or a moderate or a low risk patient. And accordingly, when you're setting your target intraocular pressure, if suppose it's advanced glaucoma with long life expectancy, and there are associated risk factor and damage occurring at low IP, definitely you'll be setting a much lower target intraocular pressure. When we were postgraduates, this is the chart we used to use. Even now, this is very relevant. When you're starting your treatment in advanced glaucoma, a 40% reduction. In moderate to mild glaucoma, 30% reduction is generally what we aim at. But this is just for starting the treatment. Over time, based on the rate of progression, whether the patient is stable or not, you have to keep reassessing your target intraocular pressure. So we always have to remember target IOP is a range and it's a dynamic value. You have to keep resetting every 4 to 6 months based on the response of your therapy. Mostly worldwide, prostaglandins have become the drug of choice. In India, beta blockers are still very popular. But then when we are setting a target, we have to see which drug can take me to my target intraocular pressure. And prostaglandins definitely are the best options because they give you the best IP control, the least systemic side effect, and they give you a 24-hour IP control. But India, if you see the most recent 2023 data also, the most two popular drugs in India are the timolol and the brimonidine and timolol combination. So IP reduction with prostaglandins are the best. Now, when to switch and when to add. And EGS has given a very simplified guideline. Whenever you're starting medication, if the IP lowering is less than 15%, we assume that the patient is a non-responder. We try a different class of medication. But if the IP reduction is more than 15%, we are not able to reach our target IOP, we'll add a medication. And whenever using 2 or more medication, try to use combination drugs, which definitely makes life simple for the patient. The cost is less, the preservative exposure is less. You're getting an additional therapy also, and definitely it gives you a more easy regime for the patient to follow. Apart from prostaglandin, the best adjuncts we have are the carbonic anhydrase inhibitors, the brimonidine, beta blocker, and now we also have the ROCK inhibitor. There are various studies highlighting the efficacy of each drug, but overall the consensus is anything between 10 to 15% of extra IP reduction you can get with an adjunct. All of them have their advantages and disadvantages. Beta blocker definitely is more cost effective. They have higher systemic side effect. The efficacy is less at night, but the IP reduction is good at par with any other adjunct. If you have a patient where you are suspecting ischemic factor, you're looking at disc hemorrhages, there are other ischemic factors, patient has a poor cardiovascular profile, these patients, a carbonic anhydrase inhibitor can be a better option than a beta blocker. Brimonidine is useful in non-mutational glaucoma patient as an adjunct. You are not only bothered with intraocular pressure, you are also looking into a neuroprotection. Definitely a brimonidine can be a good option. A ROCK inhibitor can be used in all types of glaucoma, especially in non-mutational glaucoma also they are useful. They are supposed to be both vascular and neuroprotective. However, they come with some newer complications. The hyperemia rate is very high. But at the same time, you have other risk factors like subconjunctival hemorrhages, and sometimes you can develop these reticular corneal edema. Also in a busy practice, you need to classify your patient, which patient need extra attention, which patient we can be seeing as a routine case. For example, you're seeing say 60, 70 glaucoma patients in a day. What we always do, I'll highlight in a file which patient needs a close follow-up, so I'll put a star mark. So you classify patient in OPD into safe and unsafe zone, the way highlighted by Dr. Anders Heil. So if suppose I've got a young patient with long life expectancy with moderate to advanced glaucoma, I'll be extra careful because these are the patients who have a high risk of getting blind over time. On the other hand, I've got a very old patient with early glaucoma, I'll probably be a little easy with that patient. Also, the recommendation is that in first 2 years, try to do 6 fields. Most of us do visual fields every 4 to 6 months. So doing 6 fields in 2 years is actually not that difficult. So if you're doing fields every 4 months, you can do 6 fields in 2 years, which will help you to get a VFI plot and see the rate of progression. If the rate of progression is less than 1.5 and you can see the patient is maintaining his vision, you can just keep the patient under treatment. If it's a steep rate of progression, the vision is going down, in this case you need to consider stepping up a treatment. But it's a very steep rate of treatment, more than 2 decibel per day, per year, you need to relook at the patient. Maybe you might have missed a closed angle, you might have missed a pseudoexfoliation, maybe there is some serious issue with compliance of the patient. So treat the patient as a new patient, relook at the patient again. But coming to maximum medical therapy, mostly we use 2 bottles or 3 drops in a day, so something like a brimonidine with a brinzolamide with a prostaglandin timolol combination can give you 3 drops per day and 4 medication. But now with the triple drug available and even the prostaglandin with ROCK inhibitor in the pipeline, you may get 5 medications with just 3 drops per day. So just to summarize, just key points: always write your diagnosis before treating your patient, do a risk profiling, then you can set a target intraocular pressure better. Always start with the monotherapy. Now with the triple drug coming up, a lot of time there's a temptation to start 3 drugs. Never do that. Always start with single drug, see the response, and then you add medication. Switching or adding, we have already discussed. Combination drug wherever possible. And if the patient is progressing on maximum medical therapy, consider going for SLT or a surgery. Thank you.
Yeah, thank you, Dr. Maneesh, for giving a good guideline for starting treatment. And it's really, these are all basics and we must follow to the core. And one point he said that because of the combination of 3 medicine which has been launched now in the market, so never start with the first thing with the triple combination unless you have tried all